a Puscast covering the first 14 days in February in the year 2020. References are available at edgydoc.com. And now, thanks to a request, I'm including a DUI. No, wait, that's driving under the influence. It's the DOI, making it easier for you to find your paper. Otherwise, this particular Puscast is running a little behind. The normal weekend I would do this, I was in Hawaii. I so need to go back. And I will muddle through this over the next couple of days after work until I complete yet another fascinating Puscast. But for now, let's move on to the literature, shall we? We'll start off with some antibiotic/stewardship issues. The first is a report on the use of ceftolozane tazobactam as constant infusion rather than the usual Q8, and it worked out nicely for patients. The advantage for constant infusion is you can give it easier in the outpatient setting. Q8 is usually difficult to set up, but a once-a-day swap of the bag as constant infusion is a much easier way to give this agent. I have yet to need to give ceftolozane tazobactam to anyone. The Pacific Northwest still seems to be pretty much free of those MDRO gram-negative rods for which these antibiotics are aimed. I suspect it's the beer. One of the unspoken rules of antibiotic usage, and it's a stupid rule, is once an antibiotic is started, if the patient responds, you never change it. And you never change the class. So you always stick within the cephalosporin or the quinolone or whatever you started with. And as is pointed out, patients get started on cefepime, and then the susceptibilities come back, and the organism is susceptible to, say, ceftriaxone, but people don't change the antibiotics. In this particular study, they used cascading susceptibilities so that if ceftriaxone was susceptible, they did not report cefepime, and as a result, cefepime usage went down. That's one of the important ways that one can do antibiotic stewardship is not reporting antibiotics, because if people don't see it, they won't use it, and they will use what they see on the report. But at some basic level, these antibiotic stewardship issues always annoy the hell out of me. I mean, we don't have oncology stewardship programs. Why? Because the only people that are allowed to give chemotherapeutic agents are people who know what the hell they are doing. That doesn't seem to apply to antibiotics. Although it's raging in China as I speak, I'm not going to talk much about COVID-19 because there's just too much information that is uncertain in reference to this particular organism. I will, however, make 3 notes from the literature this week. One is it is spread from person to person. The other is that it is associated with an increased LDH, which would imply, at least to my mind, that it is infecting type 2 pneumocytes in the lung and destroying them. But as a rule, elevated LDH for pulmonary processes is in the purview of pneumocystis and drug lung, and maybe COVID-19 as well, although the article did not mention the specific levels of the LDH. But that might be a hint, especially in severe disease. And then there was a horrible report of a Chinese director whose parents and sister all died of COVID-19, all within a very short time of each other. It makes you wonder if there is a genetic predisposition for dying from this coronavirus. There are studies about influenza out of Utah, where the Mormons keep a very close family history, and there seems to be a genetic predisposition to dying from influenza. I don't see why there wouldn't be a similar predisposition, although what the exact nature is, to coronaviruses. To paraphrase Shakespeare, the answer lies not in the stars, but in our polymorphisms. HPV vaccination is not part of my practice as a rule. It's a disease, or at least a treatment, that's given to adolescents, which is under the age for which I treat people. You have to be old enough to be drafted before I will take care of you. But this looked at the efficacy of the vaccine against high-grade cervical precancerous lesions, And they found that 1, 2, and 3 doses of the vaccine were all similar in protecting patients from cervical precancerous lesions. So if a patient misses out on a couple of doses, as is often the case, they may still be protected. And a second study on what to do about herpes simplex reactivation in patients on a ventilator. The prior study showed that it slowed the progression to death. That doesn't sound like a great intervention. This study randomized patients to acyclovir or placebo with HSV on a mechanical ventilator and found that the use of acyclovir did not decrease the ventilator-free days. So it appears that when you get reactivation of HSV or other herpes viruses in the respiratory tract of ventilated patients, the treatment of choice is to ignore them. So I know the world is occupied with COVID at the moment, and there was a report today that suggests it may be fecal oral spread as well, which would be very annoying. And kind of unusual, organisms tend to be very fastidious about how they are transmitted. To be both respiratory and fecal oral, well, that would be peculiar, but who knows. But as we worry about COVID, don't forget that we have yellow fever and chikungunya and dengue lurking in the background, still waiting to cut loose in the future. There was an article in the MMWR looking at the source of dengue in the United States, and the vast majority of cases were not unsurprisingly associated with travel. But I thought it was interesting. The other cases were found in Texas, Florida, Hawaii, and New York, where patients acquired their dengue in those particular states. The Hawaiian outbreak is well known, and Texas and Florida sit around the Caribbean close to the mosquito vectors and a large amount of dengue. But I thought it was interesting that one person acquired it in New York State. Unfortunately, they do not give details as to the origin of the New York case. I assume this would be the equivalent of Suitcase malaria, a mosquito hitched a ride from an endemic area to New York State. I flew back from Hawaii, and there was a fly that was picked up on the trip that buzzed around the cabin for the entire flight, presumably getting off in Portland as well. Hopefully, said fly did not carry any communicable diseases from Hawaii. A couple articles on the risk of myocardial infarction in patients with HIV disease. It's long been suspected that perhaps darunavir is associated with an increased risk of a heart attack compared to atazanavir. This study looked and found neither were associated with an increased risk of myocardial infarction. But there are other reasons HIV patients have an increased risk of cardiovascular disease. As I keep harping on, being infected is to be inflammatory, and to be inflammatory is to be prothrombotic/atherogenic. There are 2 studies that looked at the cytokines associated with myocardial infarction in HIV patients, and I'm afraid I am not a cytokine maven. To me, cytokines are kind of the modern equivalent of evil humors. Like the immune system, it's just too complex for my little mind to wrap around. My life is still me find bug, me kill bug, me go home. And since remembering cytokines has no clinical utility whatsoever, I don't remember them. But I still find them interesting. Even if my memory has gone to pot. I always say I call my wife Honey. That way I don't have to remember her name. So, interleukin 10 is an anti-inflammatory cytokine. And in people with HIV who have a tenfold decrease in their IL-10 have a 2.6 increase in their odds of coronary artery plaque. So one of the downsides of HIV is perhaps the downregulation of anti-inflammatory cytokines, in this case, interleukin 10. And then you have your pro-inflammatory markers. In this case, interleukin 1, which is pro-inflammatory and pro-atherosclerotic. And in HIV patients with elevated IL-1RA and IL-1R1 have an increased risk of myocardial infarction compared to controls. So HIV patients who have upregulated pro-inflammatory cytokines and downregulated anti-inflammatory cytokines both have increased risks of myocardial infarctions. But that's kind of like knowing about the weather. Everybody complains about it, but nobody does anything to change it. So I'm sticking with my theory that from a practical point of view, cytokines are like evil humors. Ooh. Rifampin is a critical drug in the treatment of tuberculosis, but unfortunately it kicks in the P450 system, which makes giving many medications problematic, among them protease inhibitors. Is there a protease inhibitor you can give in addition to rifampin? And the answer to that would apparently be dolutegravir, which does not particularly kick in the P450 system, and in this study was well tolerated, did not lead to HIV resistance or failure of TB treatment. So that would be the protease inhibitor of choice if you were treating a tubercular. Not unsurprisingly, those that use PrEP, pre-exposure prophylaxis for HIV, are unlikely to use a condom and will not use a condom. And the consequence of this, at least in Germany, was a high prevalence of sexually transmitted diseases that were often asymptomatic. The suggested solution in the article is comprehensive STI testing as well as counseling, like that works in anybody. But I do remember, I think it was a French study where they used doxycycline as a pre-exposure or a post-exposure prophylaxis in men who have sex with men, and it did show a decrease in STIs. It's a problematic intervention for a variety of reasons, but I doubt counseling is going to be effective in anybody. People do what they do. A study that is probably more widely applicable than just the patients studied in this study, he said using the word study too many times, but they looked at the efficacy of the pneumococcal vaccine in patients with inflammatory bowel disease and found that patients, although they often responded appropriately 60% of the time while on immunosuppressive agents, those who were not on immunosuppressive agents did better with their response to the pneumovax. So if you have any patient going on immunosuppressive drugs, if you can, you should get all their vaccinations in before you start their immunosuppression. Not just inflammatory bowel disease, but probably anyone who's going to be placed on immunosuppressing medications. There was a big outbreak of listeria in South Africa. What always interests me about outbreaks is not so much the organism, but what was the source of the outbreak. I find that to be, for some reason, always interesting. In this case, it was due to a ready-to-eat processed meat, and it was a meat called polony, P-L-O-O-N-Y. I thought, what's that? Bologna made out of ponies? Well, in case you're interested, polony, to quote the webandsausage.com, is a soft-textured English large smoked sausage typically made of pork and beef. It is usually sold encased in a vividly hued skin of either orange or red. Polony sausage is similar to bologna, so its name suggests that polony might have been brought from Bologna, the Italian city known for this style of sausage. It is often used in a popular street food, a sandwich type product called cotta, K-O-T-A, and has at least a 5-month shelf life. Looking at the cotta, it looks quite delicious. They hollow out a baguette and stuff it with meat and French fries and sometimes listeria. It looks yummy. But I digress. But this is the kind of rat holes that I think make infectious diseases so interesting. Now, to move on from the delicious, if contaminated with listeria, to a slightly more scary article. Group A strep, strep pyogenes. I can kill that bugger, right? Well, maybe not. One study out of Japan shows that increasing resistance to both quinolones and macrolides has been occurring over the last 10 years. No big surprise, but they said beta-lactams still remained effective. Or are they? There's a very scary article, because group A strep is one nasty bug, that looked at a huge number of Streptococcus pneumoniae, 7,025 genomes, and found that they were having alterations in penicillin binding protein 2X that was decreasing the efficacy of penicillin against group A strep. They found 137 strains that had a variety of mutations in the penicillin binding 2X protein to decrease the susceptibility to penicillin, and these were spread all over the world. If there was ever a cue for the theme from Jaws, that is it. The last thing I want is a beta-lactam resistant group A strep, eagle effect notwithstanding. I usually group my articles from least genetically sophisticated to most genetically sophisticated. That's why I tend to start with antibiotic stewardship articles. This one probably should have been with the listeria, an outbreak of E. coli OH157. Where did they all get it? Soy nut butter. So I think the take home is if you're making coda, don't make it with soy nut butter. You'll get 2 bugs for the price of 1. So a patient comes in with flank pain and you get a CT and it confirms pyelo. Often the radiologist telling you that, yeah, they have perinephric fat stranding. Oddly, that was seen on the CT of my head. But what is the significance of perinephric fat stranding? Well, someone's looked at that. Patients with perinephric fat stranding had slightly higher average temperatures, but more importantly, they were more likely to be bacteremic. 55% had bacteremia versus 23% who did not have perinephric fat stranding. So if you're looking for an indication to do blood cultures in a pyelonephritis patient, the presence of perinephric fat stranding on CT should push you towards getting blood cultures. And as long as we're on the topic of blood cultures, one of the issues is, what question are you asking? If it's endocarditis, you want cultures done over time, sustained bacteremia being the sine qua non of endocarditis. And if you just want to know, is the patient bacteremic, then it's just a matter of volume. You want to get enough blood out of the patient so that you'll have a positive culture. Ideally, you would do 6 liters, but the patient would probably tolerate that poorly. I talked about in the last podcast, the study that showed when you got appropriate volumes of blood for blood cultures in adults, you increased the yield. This study in open forum infectious diseases in pediatrics showed the same result, that if you got age-appropriate volume in your blood cultures, you are much more likely to get the infecting organism, and also it made it easier to get appropriate therapy into the patient. So regardless of age, if you're getting blood cultures, get as much blood as you can, at least enough per the blood culture bottles, to increase the yield of your blood cultures. As Shakespeare said, the answer lies not in the stars, but in ourselves. This study looked at the development of ARDS in sepsis and interestingly found a genetic predisposition in patients who had sepsis-associated ARDS. What was that genetic commonality? Who cares? Well, actually, I'll mention it. I'll read you the conclusion, although I, for one, will never remember anything except that ARDS has a genetic predisposition. Quote, a common variant within the FLT1 gene is associated with sepsis-associated ARDS. Our findings support a role for the vascular endothelial growth factor signaling pathway in ARDS pathogenesis and identify VEGFR-1 as a potential therapeutic target. There, you heard it. Now, let's see if you can forget it faster than me. I, for one, will probably only remember the specifics once it becomes clinically relevant. IV dogma for years has been Staph aureus bacteremia needs to be treated with a minimum of 2 weeks of IV therapy. Now that dogma is slowly eroding. Yet another study This looked at the efficacy of early switch with beta-lactams in low-risk Staph aureus bacteremia. What's low risk? Healthcare associated, no evidence of deep infection, no prosthetic material, no further positive blood cultures. And these patients all had MSSA and were switched over to oral beta-lactams. And this was out of Europe, so it's flucloxacillin. And they did just fine, thank you very much. So it's increasingly clear that low-risk Staph aureus bacteremias can be treated with oral therapy. I have to admit, I've been more willing to do that with MRSA because the oral agent linezolid is probably as good as the IV therapy. And I've always been hesitant to do it with MSSA, but maybe I will. But treating MSSA with oral therapy for me feels like performing an unnatural act. But like most humans, you quickly become accustomed to unnatural acts. And they eventually become some of the best parts of your life. Or is that TMI? And here's another potentially practice-changing article. Most of the diabetic foot infections that are admitted to my hospitals get started on some sort of broad-spectrum beta-lactam plus vancomycin. This study looked at the efficacy of nasal screening for diabetic feet infections and the negative predictive value if your patient had no MRSA in their nose was 89%. That's pretty good. If you know your patient is MRSA negative in their nose, you probably can wait on the foot cultures before instituting vancomycin. And in this study, just how often was MRSA isolated in the foot? Well, 7.5% of the time. So it's also a fairly uncommon cause of diabetic foot infections. Also, Pseudomonas was only found 6.8% of the time. So most of the time, I think most diabetic feet need cefazolin and surgery more than antibiotic choices. This is assuming, of course, that the patient is clinically stable. I remain of the opinion that no one should be allowed to order echoes to rule out endocarditis without infectious diseases approval. The vast majority of echoes that are obtained to evaluate for endocarditis are in patients who have almost zero prior probability that you're going to find a vegetation. So doing a shitty exam on someone with no prior probability leads to the needless expenditure of money to no good end. One of the times you see patients get echoes for rule out endocarditis is for septic arthritis. Don't do it. Out of 263 patients with a septic joint, a mere 3.7%, 19, had endocarditis, and it was most associated with those with positive blood cultures, especially with Staph aureus. Then again, if I had Staph aureus in the blood and a septic joint, I treat for endocarditis regardless of the echo, so why get it? I wonder how much money the system would save if I was the echo czar and you had to have my blessing to get a TTE to rule out endocarditis. And then there was a study that looked at the use of extended antibiotics in patients who had total knee arthroplasties. And they found benefit for patients being kept on chronic suppressive antibiotics. But the interesting aspect of this study is they did not show any benefit of continuing the antibiotics past 1 year, which I found interesting. On then the other hand, I had a patient with chronic suppressive antibiotics for Staph aureus, and after 2 years, a doctor in Palm Springs told him to stop his oral cephalexin, and 2 weeks later, the MSSA was back. So I don't know. With Staph, I'm still kind of inclined to lifetime suppression, but I have this conversation with my patients, and most of them elect for lifetime suppression. But if I have a streptococcus or some other less virulent organism that is easier to kill, 1 year may be a lot more reasonable. So there has been all this literature on how good PET scans are for a variety of infectious disease processes like FUO and Staph aureus bacteremia, etc. For those of you who are fortunate enough to practice in some places not the United States and its absolutely insane healthcare system, you probably don't realize that it is a real issue ordering PET scans, which cost a lot of money here and are difficult to get approved. This study looked at PET scans with endocarditis and found that it was predominantly beneficial in patients who had prosthetic valve endocarditis and was a good way to make the diagnosis, but not as valuable in native valve endocarditis. But then, practically speaking, native valve endocarditis is not as big a deal, as you usually don't need to take the patient's valve out. Where if you have prosthetic valve endocarditis, that's much higher on the possible to-do list. But another example of the utility of PET scans in the world of infectious diseases. I think in 35 years I've seen 3 cases of Whipple's, so I don't have the greatest of clinical experience. This was a curious case report, a patient on prednisone and methotrexate who presented with CNS problems, meningitis, encephalitis, cranial nerve issues, and had isolated CNS Whipple's disease, but did not have it elsewhere. So add Whipple's to the possible organisms to cause encephalitis in the immunocompetent. More often than not, patients with empyema, or at least a exudative pleural effusion, often don't have positive cultures, and you shrug your shoulders. This study is also practice changing in that they use multiplex bacterial polymerase chain reaction to look and see what was in these complicated pleural effusions. And where the culture was not all that great, it grew organisms about 7% of the time. A fifth of the time, the PCR found organisms. But what were they? The vast majority were anaerobes, which kind of surprised me, followed by gram-negative cocci and then gram-negative rods. So if you have a culture-negative empyema and you don't have access to multiplex PCR, remember that the organisms you need to treat are a combination probably of anaerobes and streptococci. And like many infections, being culture negative doesn't mean the space is not chock-a-block full of bacteria. There has been a lot of immigrant demonization in the last 3 or 4 years for some reason. I don't know why. I don't pay attention to the news. This study out of Italy looked to see if it was migration that was the cause of Mycobacterium tuberculosis resistance rates. And they found that the increase in MDR-TB was equal in both Italians and foreign-born patients, suggesting that it was not migration that was the cause of the increased prevalence/incidence of resistant Mycobacterium tuberculosis. Although I don't think walls would be a very good preventative for infectious diseases. There was a flurry of Mycobacterium chimera infections a couple of years ago. It was associated with contamination from the water, specifically the ice used in open heart surgeries. It's a cousin of Mycobacterium avium, and a variety of infections associated with open heart surgery were associated with this organism. Sternal wound infections and endocarditis and prosthetic valve endocarditis. There's also now a case report or reports of 3 patients who had fatal disseminated Mycobacterium chimera infections as a result of their cardiac surgeries. So the organism being on the valve, or at least in the bloodstream, would seed the CNS and cause a progressive illness. And it's not the most treatable of infections. So again, add that to the list of potential infections that a patient can get after open heart surgery. And we have Newton's second law of the medical literature, which states that for every study there is an equal and opposite study. The question is whether or not everybody with candidemia needs an ophthalmologic exam, because not everybody with candidemia seeds their eyeball. And some studies have suggested that the patients in whom you should get an eye exam are those who give a history of visual changes or who cannot give a history because, say, they're sedated. This study contradicts that and suggests that it's more common than suspected to have fungal balls in the back of your eye, and that, quote, early routine ophthalmologic examinations found a high incidence of advanced ocular lesions. These results suggest that routine ophthalmologic examinations are still warranted in patients with candidemia. I don't know. I hate routine anything. I remember my years as a fellow, I infected rabbits with Candida and saw if fluconazole was effective. And one of the interesting things is that in normal patients, or in normal rabbits, Candida endophthalmitis got better on its own. It just got better faster if you had patients on antifungals. So I still wonder if everybody with candidemia needs an ophthalmologic exam, or should it be limited to symptomatic patients, since A, patients with fungemia are going to get a good course of antifungals anyway, or so I would hope, and B, it's going to get better on its own even if you don't treat. So what's the purpose of getting an ophthalmologic exam if the patient is asymptomatic? I remain uncertain. And I doubt we will ever have a definitive prospective clinical trial to address the issue. And I have long resisted the concept of doing things because you're worried about malpractice. I basically do what I think is best for the patient every time, and things will fall out as they will. And a study to show that the 1,3-beta-D-glucan is not a bad study for diagnosing fungal meningitis, depending on the organism. They also diagnose cryptococcal meningitis with this test. The usual rule is that Cryptococcus does not make 1,3-beta-D-glucans, but it does, just very small amounts. And I've seen positive 1,3-beta-D-glucans in patients with whopping cryptococcal disease. But if you have a worry about a fungal meningitis, the antigen tests are not a bad study to order because cultures take too long. And if you're worried about fungal meningitis, the sooner you diagnose it, the better. I don't tend to think about amoebas per se. I mean, I know that amoebas are the organism that Legionella infects, and that, in fact, Legionella is spread in part because of amoebas. This study looked at paracoxy and amoebas, and it looks like paracoxy is in an ongoing lifetime battle against soil amoebas like acanthamoeba, and that many of its virulence factors are there to prevent it from being killed by amoebas, which I think is just kind of an interesting little bit of ecological factoid. And as long as we're on the topic of amoebas, there was a case of a patient with overwhelming amoeba infection, acanthamoeba, I can't pronounce it right, castellani, which is the same one that infects and kills paracoxy. This patient had CLL and was being treated with ibrutinib and got an overwhelming case of acanthamoeba as a result. Yet another weird bug in an immunoincompetent patient. And that brings us to an end of our Puscast, a review of the infectious disease literature covering the first 2 weeks of February in the year 2020, the year of perfect vision. References are available at edgydoc.com, the home of my multimedia empire, and also available on the MP4. Per request, I now include the DOI. If I remember right, someone was using these podcasts to help generate ideas for their journal club, which is kind of scary. Someone from Australia, I believe. But it was a good idea, and I thank you. Otherwise, I have nothing else to say, so thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along. Thank you. In dictation, Take it away, Jeff.